Good morning. I am Christy Connor. I'm the host of Friday Coffee Meetup. We are so excited to have you here with us today. Friday Coffee Meetup is the largest active entrepreneurial innovation tech meetup in Los Angeles, California. We have about 7,000 members, of whom we're super grateful for them, especially during this time where we're transitioning from an in-person meetup due to the coronavirus crisis. We're transitioning over to being a virtual meetup. And as you can see, although you see my face right now, there's a whole team of volunteers behind me that make all this happen, especially during this time where personal lives and work lives have been in chaos. They've put their community first and turned it over to being a virtual meetup. So I'm super grateful for them, as well as Echo Factory, who sponsors us as well. I want to let you know that Friday Coffee Meetup also has a YouTube and a podcast channel. So if while you're at home and are looking for something to do, we have a lot that you can learn. We've had great speakers for many years. Those are all on those channels. So brew a cup of coffee and check those out. For logistical challenges here as we go into Zoom, this is our first time hosting via Zoom. We apologize in advance for any technical issues. To try and minimize any technical issues that we might have, there's a few things that you'll notice that I put in the chat window. One is that you've all been muted on entry, except for myself and Dr. Shriner. Also, we ask that you keep your videos off. I might kill your video if I see it happening. We're trying to make sure that we have the right amount of bandwidth in order to be able to make sure that this goes successfully. We will have Q&A, as we normally do at our meetup. It will happen at the end, and it's going to happen via the chat box. So what I would ask is that you put your question into the chat box. I will try and aggregate those questions. Please be brief in your questions. And we do apologize in advance. I might not get to all the questions, but we do thank you for providing us your questions. I'm honored today to introduce Dr. Kimberly Shriner. She's going to be talking to us today about life in the time of coronavirus, an update on the pathogen. Dr. Shriner practices infectious disease and tropical medicine at Huntington Hospital and also within the Pasadena community. She's also the director for the Phil Simon Clinic, which helps serve underserved HIV patients out of Huntington Hospital, and that work also extends into Northern Tanzania as well. With that, I'm going to stop sharing. I'm going to turn it over to Dr. Shriner and say, welcome, Dr. Shriner. We know this is a very challenging time, and we're so grateful that you were able to spend some time with us this morning. So with that, I'm going to stop sharing, and Dr. Shriner, you can go ahead and share on your side.
Okay. Oops. Let me get over here. Let's see, how do I do that again, Christy?
It's just at the bottom. If you hover over the bottom, you'll see the share screen button in green.
Yeah.
And then go ahead and click on the screen up in the left, and then click share at the bottom right.
Oh, there we go. Wait a minute here. Okay.
There we go. We can see. Thank you.
Can you see the slides and everything?
Yes, we can see the slides.
Okay, good. All right, let me get rid of this. There we go. Okay, well, thank you very much, Christy. I appreciate the introduction. And I'm just going to give an overview of the current situation with coronavirus. As you know, many of you, I'm sure, are following this in the news. It's sort of pervasive throughout life, and it's a pretty scary thing. It's not that we hadn't anticipated having to deal with another pandemic. I think most of us thought it might be an influenza pandemic, but we have dealt with coronavirus in the past, and I will talk a little bit about that as we move along. I think I wouldn't recommend reading The Plague right now if you as it may make you a little more depressed, but Camus was certainly prescient in some of the things that he talked about in that particular book. And I think that's very true, that none of us really know where this is going to go or what's going to happen at the end. But those of us that are in medicine certainly need to pay attention to what we're doing with our patients and to protect our community. So pandemics have not been something that we haven't had any experience with really throughout civilization. Of course, the Great Black Plague during the Middle Ages and Renaissance, but even in the last 100, 150 years, we've been dealing with the pandemics. The most famous, of course, was the 1918, 1919 H1N1 Spanish flu epidemic that infected about a third of the world's population and killed about 50 million people. In the 50s and 60s, we had a recurrence of a couple different types of influenza pandemics. And of course, in 1981, when I was beginning my career in medicine, the HIV pandemic hit. And many things about that pandemic are being replicated with this pandemic. This disease is transmitted in a different fashion. But I do think that the fear and unfortunately the stigma and sometimes the misinformation issues that went on at the very beginning of the HIV pandemic are certainly similar to some of the things that we're seeing now with the coronavirus problem. 1993 was a very small epidemic, the hantavirus outbreak, but it was similar because that too was a zoonotic infection. It came from animals, was a previously unidentified pathogen. And although it didn't kill too many people, it did cause quite a bit of mortality and is a very lethal virus. We're quite lucky actually that this virus is not a hantavirus. In 2009, we had the H1N1 flu virus pandemic, which also was a substantial it caused a substantial amount of mortality and morbidity. And then perhaps as a preview of coming attractions, in 2002 and 2003, we had the first SARS coronavirus pandemic that was largely limited to Asia, but bears a great deal of resemblance to this particular pandemic, at least in the virology. Of course, the most recent pandemic that was equally scary was the Ebola outbreak in 2014 in West Africa. That didn't impact the United States except for one isolated area in Texas and a few individuals who'd come back from West Africa, but it certainly had the potential to be a problem. And we at Huntington Hospital spent some time getting ready for that, which has turned out to be fortuitous for this particular pandemic. I do want to remind people that influenza continues to be, excuse me, a very significant pathogen. And even during this season, we've already had 13 million cases of influenza and 300,000 hospitalizations and anywhere between 30 to 40,000 deaths just due to influenza. There are some substantial differences between influenza and coronavirus SARS-CoV-2, the virus that causes this particular pandemic, and I'll talk about that in a second. But it is important to remember that we deal with this kind of problem frequently, perhaps not on this scale. So these were the statistics as of last night. They, of course, have changed a little bit since then. We've had over 1 million cases now globally of infection with SARS-CoV-2, the virus that causes COVID-19, the disease. Unfortunately, 52,000 deaths throughout the world. That number is increasing. Around 250,000 cases in the United States with about close to 6,000 deaths. And LA County is up to over 4,045 with 78 deaths. And so those numbers, of course, are changing hour by hour. And we are certainly not at the other side of the curve when it deals with this virus in the United States. So what is SARS-CoV-2? SARS, of course, stands for Severe Acute Respiratory Syndrome, Coronavirus Type 2. It is an RNA virus. These are very small, there's small viruses, but they have a large genome. They usually affect birds and mammals, not reptiles. And of course, we're very familiar with coronaviruses because they're a cause of the common cold and frequent upper respiratory and not infrequent lower respiratory infections such as pneumonia and bronchitis. It's called the coronavirus because of the little spikes around the outside of the virus that you can see in this electron microscope picture that looks like a crown. There are 4 different groups of coronaviruses: alpha, beta, delta, and gamma. The alpha coronaviruses are the common cold. That's usually human coronavirus 229E, NL63. The beta coronaviruses are largely in animals, and this particular coronavirus is a beta coronavirus. It is commonly found in bats. Bats are an important vector of infectious diseases and zoonotic infections, and indeed they have been the cause of this particular outbreak. This is a beta coronavirus. It probably came from 2 different species of bats in Southeast Asia, one called the chrysanthemum bat, the other one called the Southeast Asian, anyways, another Southeast Asian bat. Bats are unusual because they do not become sick with these viruses. They have a very unusual immune system that's sort of suppressed. They are, of course, the only flying mammal, and when you fly, it's pretty stressful. And so their evolutionary development has selected for an immune system that is tamped down. So they can actually carry these viruses around, not become ill with them themselves, but have very, very high viral loads. And when bats echolocate, they're actually coughing. So that may be a modality from them to spread it amongst themselves, and could possibly be a spread to humans, although it's probably there's another intermediate host, and I will talk about that in a second. So where did this virus come from? It's very clear this virus came from a zoonotic source, likely from the two different bats that are described. Horseshoe bat, that's what I was trying to think of, the Southeast Asian horseshoe bat. And it probably did come from these dreadful wet markets that occur in Asia, where unusual animals are kept in live cages and used for food and other materials. They're high value in these markets, but it's a perfect opportunity for viruses to jump from animal species to humans. The first SARS outbreak was a good example of a zoonotic coronavirus. There was a second outbreak that largely affected pigs, that did not affect humans. And of course, we still are dealing a little bit with the Middle East respiratory syndrome, or MERS-CoV virus, which is still circulating. It's not very common, but it has a very high mortality, about 70%. It's mostly in the Middle East. So the first SARS outbreak, the intermediate mammal, was probably a civet cat. And again, this was a bat to civet cat transfer of the virus, and then the civet cat to the human transfer. The MERS, as I mentioned, actually is a camel. Camels have a lot of respiratory secretions. You don't want to get on the north end of a camel. They're also kind of crabby animals, but they carry this virus and can be the source of the MERS outbreak. It's thought that this particular SARS-CoV-2 came from the two bat species that I mentioned, and then the intermediate host was something called a pangolin. There are some data now that may suggest that that isn't the case, but that's sort of the general theory. Pangolins are an armadillo-type creature that are of high value in Southeast Asian cultures, and were in this wet market near Wuhan, and may have been the intermediary source. And again, I mentioned the fact that bats are prime sources for many zoonotic infections. They are colonial animals. They live together. Bats are a very important part of the planet's ecosystem. And so destroying bats would be a catastrophic thing to do. They're very good at removing other types of disease-causing vectors, such as mosquitoes and other flying insects. So they really serve a purpose, but they also are a source of ongoing infection. And with destruction of natural environments, with some global warming issues, and with their ability to fly, we are certainly encountering them more often. And when humans encounter a virus that they've never seen before, the virus can often become more virulent as it jumps from one species to another. And that seems to be what happened with this particular virus. So as I mentioned, coronaviruses are called coronaviruses because of these spikes that occur on the outside of the virus. There are four main proteins: spike proteins, nuclear proteins, membrane proteins, and then a small envelope protein, as well as a hemagglutinin esterase dimer. These are all potential sites for therapy and also for vaccine development. The spike protein is perhaps the most important because that allows the virus to attach to respiratory epithelium in humans and in other mammals. We don't have to go into too much of the virology, other than the S protein is probably the most important. It allows the virus to attach to the receptor cells. In humans, that tends to be the angiotensin converting enzyme type 2 cell, which is spread out through the upper respiratory mucosa and down into the lungs. And this virus very much likes to go to the lungs. In patients that have COVID-19 disease, it's pneumonia and adult respiratory or acute respiratory distress syndrome that is the manifestation of this disease. So the virus attaches to these receptor sites and then starts causing a great deal of inflammation. It can actually mediate cell-to-cell fusion of the virus and create these rafts of cells called syncytia, and that increases the amount of tissue that's destroyed and leads to all kinds of calamities that causes morbidity and mortality. So how does it infect humans? We know that humans spread this disease through droplets, through infected droplets. And this has been sort of a source of confusion in terms of protective equipment and how we worry about the virus moving through different communities. But it very clearly is a droplet-mediated infection. When people sneeze or cough, as you can see from this picture, it's not uncommon for them to spray a great deal of very tiny little molecules of mucus into the air. And if you're within 6 feet or so of that particular event, it's very likely that you'll inhale those droplets into your own mucosal membranes, and that's how the infection can be transferred. There are some data that are now coming out that show that the virus may be suspended in the air a little longer than we thought, perhaps up to 3 hours. Some kind of scary data that came out of a New England Journal study, which I'll show you in a second. But whether those droplets are still infectious, we're not sure. We know that the main modality of transmission is through mucous membranes and droplets. If you look at the data that was collected in China during the beginning of this outbreak, most of the people who acquired the disease were family members of someone who was the vector. They're not necessarily random people. So we do know that close contact is a very high risk factor. However, that being said, if the mucous membranes land on a surface, especially a hard surface, they can remain, virus can be detected over several hours on that surface. It does need to be sort of suspended in mucus. And the other piece of this is we don't know if you can isolate virus several hours or even days after a contamination, is that still infectious? We don't know the answer to that question, but presumably for the first few hours while that mucus is sitting on a hard surface, if you touch the mucus and then inoculate yourself a mucous membrane, then you can certainly become infected. I just want to say that an airborne pathogen, our examples would be measles or tuberculosis. One of the things you may hear about is the R0 value, which is the transmissibility of viruses or infectious diseases. The R0 value for influenza is a little bit less than 1. The R0 value for SARS-CoV-2 is about 2 to 2.5. The R0 value for something like measles or tuberculosis is around 5. Those are airborne diseases. They stay suspended in the air and are much, much more infectious than this pathogen. We talked a little bit about the angiotensin II receptor site that people express on their respiratory epithelium. There may be habits that people do that increase the expression of this receptor, such as smoking or vaping. We certainly know that people that have pulmonary disease are much more likely to have more morbidity and unfortunately more mortality associated with this disease if they become infected with it. And that may be a role of the angiotensin II receptors. This was a cartoon that came out of the New York Times a few weeks ago that I thought was quite helpful to sort of show what happens when the virus, how it enters and what it does. So the little spikes on the outside allow them to attach to these receptor sites. The angiotensin II receptors are sort of similar to the CD4 receptors that we see in HIV, although this virus, of course, is a very different type of virus than HIV. But suffice it to say that it uses those sites to enter the vulnerable cell. And then like all viruses, it actually uses the cell's machinery to duplicate itself. So after it enters the cell, it begins to release its own genetic material, and it hijacks your cells, the receptor cells, machinery that makes proteins, and it converts that into a virus factory. It assembles new copies of the virus, and then those are released when the cell is killed. And of course, these are in thousands and thousands, if not millions of viral particles, and then that goes on to spread the infection very, very rapidly. One of the things we're learning a lot about, and perhaps one of the issues associated with the morbidity and unfortunately mortality with this disease, is that the body elicits a pretty profound immune response. That's a normal thing to do in infection, but sometimes the immune response can get out of control, and that can actually be worse than the actual infection itself. And I can talk about that a little bit. We are looking at using immune modulators in some of these patients. I've had some experience in one patient of mine last week that we used an immune modulator, and it seemed to help a little bit. But that is a parameter that we follow as patients are admitted, especially those that are critically ill, into our ICU. We do follow a lot of the immune-mediated molecules, and we can talk about that later if you like. And then the virus eventually is expectorated out of the body and contaminates other people. One of the things we want to look at then, of course, are antibodies to the virus, and we think that this will probably be the mechanism for vaccine development. Perhaps before vaccine development, it might be a mechanism for therapy. Many of you may have been sort of following along the interest in giving protective antibodies to people who have had the disease but recovered and now have IgM and IgG antibodies, using the plasma from those people as a potential therapy for critically ill patients. It has been done a little bit in China, but not extensively, and the data is still very, very new on that modality. I will tell you from personal experience that a lot of these things were done early on in the HIV epidemic and really didn't prove to be very helpful, but desperate times require desperate measures, and so that may be something that we do down the road. How does soap work? Obviously, washing your hands is probably the most important thing to do during this pandemic, and what happens is the soap disrupts the lipid membrane of the virus, and so the virus denatures very quickly. These are rather delicate little viruses. When they're on a surface, they can be killed very easily with 70% alcohol or bleach. Bleach is kind of the universal safety agent. It works even for Ebola, so I think bleach is a very, very good antiseptic. But soap and water also work quite easily to destroy the virus, and that's why we encourage people to wash their hands frequently and thoroughly. So I mentioned the fact that when the virus attacks the cells, it takes over what's called the endoplasmic reticulum. That's the device in your cells that produce different types of proteins, and it basically just takes that hostage and makes it, turns it into a virus factory. But it also causes a great deal of inflammation and destruction of the endoplasmic reticulum, and this leads to the secretion of cytokines, which are a lot of the inflammatory markers that cause problems with disease, specifically respiratory failure, low blood pressure, sudden death, and so forth. Also, the virus can accumulate in cells, and that in and of itself can cause cell death. And so there's both a direct and indirect mechanism for the virus to attack mammalian cells. And I mentioned these inflammasomes. These are all different types of medications that are an important part of the immune system. They're normal parts of the immune system, but they become over-exuberant and cause a lot of disruption and then induce inflammation themselves. And it's the inflammatory response that often is the more serious problem once people become infected with SARS-CoV-2. This is a typical looking CT scan of a patient with COVID-19, the pneumonia associated with SARS-CoV-2. You can see it tends to occur in the periphery and in the dependent portions of the lungs. One of the mechanisms of therapy that we're using and the Chinese used extensively is something called proning, where you turn patients on their belly that are intubated on ventilators. And this helps improve the ventilation in areas that may not be infected with the virus. We've had minimal benefit with that. It's something that's done a lot more in Asia, but we are trying it in our ICU, and it does help sometimes to ventilate these patients. So these are how do you make the diagnosis? Well, you want to take the history, and at the beginning of this pandemic, we certainly wanted a good travel history. Had you been to endemic areas, Southeast Asia, or Asia itself, Europe, Italy, had you been on a cruise ship? The cruise ships are certainly the virus vectors of the planet, I think. They have really been a very concerning thing for many years. This is not the only virus that cruise ships have had problems with. Norovirus is a very common one on cruise ships. So it might be time to rethink our tourist industry a little bit. But then we also look at constellations of symptoms, and they're fairly simple symptoms. Fever is a fairly common one. About 70 to 80% of people will have a fever, but then of course 20 to 30% of people will not have a fever. As the disease progresses, a dry, non-productive cough is very typical. And then all sorts of viral syndromes. They can have a headache, they can have myalgias, achy muscles, they can have sweating. They may even have a little bit of diarrhea. The GI symptoms seem to be fairly common in the early presentation of this disease, but these are all very non-specific things. There's a whole host of other viruses that can do this. Influenza, of course, can do this, and other coronaviruses as well. And then the most reliable and useful test that we have is the PCR for for the SARS-CoV-2 virus. The unfortunate thing is, as I'm sure everybody's aware, is the really lack of availability of this test in the United States. Happily, this week, things seem to be changing a little bit, but for the first few weeks of this pandemic here in the United States, it was just a nightmare because we couldn't get testing done. And so we had to just assume that either patients had it and isolate them or hope that they didn't have it. The South Koreans were the most facile at developing extensive testing. It's very helpful epidemiologically because it allows people to identify sources of infection, isolate them, and then control all the contacts that they may have had. And that is the most effective way to prevent spread of the disease. So we hope as we move forward here with more frequent testing and availability of testing on the ground, not just coming from higher ups who say that the testing is available. It really hasn't been widely available until the last 10 days or so. But even still, we're not quite up to speed on that one. So that's a hugely important part of diagnostic testing. So the Renaissance and Middle Ages physicians were prescient in their types of personal protective equipment. Kind of scary, however. They would walk around in these large black gowns, and they had a covering on their head, and then they would wear this mask. And in the beak of the mask were herbs to kind of protect them from the stench of the bubonic plague. But probably would have been pretty good PPE now, if not scaring the heck out of the patients. So fortunately, we don't do that. But these are the techniques that we use. Surgical masks, which are for droplet protection from diseases such as this. In situations where there might be a high likelihood of aerosolization of the virus, such as an intensive care unit where there's a high count of viral infections, or in procedures such as intubating a patient, putting them on a ventilator, or giving breathing treatments, we recommend the N95 mask. And then finally, for our patients, we're certainly doing this in our intensive care unit for direct care, where there's a very high likelihood of contact with either aerosolized virus or contact virus. We use what's called a PAPR, and that's a very sophisticated respirator-associated suit that is used in many different hospitals. All of these things are in short supply. Even the surgical masks, the very first line of defense, there's a huge shortage. And the N95s, of course, have also been a really big problem to get a hold of. And we certainly have experienced that at Huntington, as have all hospitals. Many healthcare workers are forced now to reuse these masks. That is not ideal because the surface of the mask can become contaminated. But you are seeing that certainly in places like New York. And we've come up with different protocols to have our healthcare workers reuse them if they have to as well. This was the New England Journal article that I was talking about, and this looked at the duration of infectious particles, both suspended in the air and on surfaces. And again, what it showed is that that SARS-CoV-2 was more stable on plastic and hard surfaces and stainless steel than it was on cardboard, but that it could be detected up to about 72 hours after these things were applied to the surface of the to the contact surface. It's not clear whether those are still infectious. And one of the things we are beginning to learn is that the amount of virus that you're exposed to initially may also dictate whether you develop infection and may even impact how severe your infection is. People that have very high viral counts and exposures may have more severe disease than someone who has a sort of mild viral count. And when you think about it, this makes sense. We don't have to do that now, but for smallpox, we would actually give people a little bit of the disease, and that would create a mild illness that would provide protective antibodies when the more serious illness was encountered. So we do know that viral counts and viral loads are important in the transmission of this disease. We still have a lot to learn about whether surfaces and air areas are truly infectious, but we have to presume that they are. And so that's why we take the precautions that we do. Right now, there really are no established therapies for this disease, in spite of what some of the federal government puts forward. The potential therapies would be therapies that would target the proteins that the virus uses to interfere with viral attachment, perhaps either block those attachment sites on the virus. That would probably be the easier thing to do, or to do that in the host. To interfere with viral replication, and we do have a drug that has an application there, and I'll talk about that in a second. To interfere with the inflammatory response. Many of you have heard about hydroxychloroquine. That's a medication called Plaquenil. It's used in rheumatologic diseases. Its progenitor, chloroquine, was used a lot in malaria. the data on that is really pretty murky. There's only a few small studies, a few in China and a couple or one in France with very small numbers. It's largely anecdotal. I'm not terribly impressed with it. We've done that in the absence of having anything else to do on some of our patients with pretty mediocre, if not zero, improvement. And it's not a benign medication. It can cause cardiac arrhythmias. Also, there are many people who require this drug for their immune problems, rheumatoid arthritis, et cetera, and it's now, of course, in short supply. I mentioned the inflammatory inhibitors, and there's a drug called tocilizumab or tocilizumab. It's either a hard C or soft C, nobody seems to know. That inhibits IL-6, which is an important inflammatory mediator. I've used it once in a patient. It seemed to help, but it has a whole host of side effects. It's quite dangerous to use, and you have to be very careful. So messing with the inflammatory response can be problematic. And I will tell you, in 30 years of infectious diseases and treatments, that has always been a very attractive idea, but has sometimes had some catastrophic problems when we fiddle around with the inflammatory system itself. So I think antivirals will really be our best option, and there's always a whole host of antivirals that are being repurposed for new viruses. Kaletra, which is a protease inhibitor used in HIV, was looked at in China. It has no efficacy against this virus. Favipiravir has been a viral agent that's been used in other viruses. Seems to have a little bit of activity, but probably not great. Baloxavir is a flu viral inhibitor. But remdesivir is a drug that's a very intriguing drug. It's made by Gilead Pharmaceuticals. It was originally made to treat Ebola. It has activity against a lot of hemorrhagic viruses and many coronaviruses, including this one. It interferes with the replicative cycle of the virus. It stops the replication. And there are now 2 clinical trials going on in the United States through Gilead. It was available a couple weeks ago on compassionate use. They discontinued that program, but they now have an expanded access program that we just recently got licensed for. So we are using it, and I have used it on patients with minimal good response. But I think that will probably be the way to go. For those of us who take care of HIV positive patients, antivirals and interrupting viral replication has become a really important part of therapy and perhaps the most helpful. So I think that's probably going to be the direction for treatment of this disease. Vaccines are going to be problematic. There are many companies, big vaccine makers like Sanofi Pasteur and Merck, that are looking into developing vaccines. There's obviously going to be a lot of money in vaccine development, but it's a very cumbersome process, and the early human trials have just started, which are phase 1 trials looking at the toxicity of potential vaccines. We also have to make sure that the vaccine doesn't make the situation worse. There are some viruses, dengue, for example, that if you vaccinate people for the virus and then they encounter the real virus, they actually get sicker. I don't think that's going to be the case with coronaviruses. They're upper respiratory viruses, and I think they will lend themselves to a vaccine. But I think a really useful vaccine is probably at least 12 months, if not 18 months away. So that's not something we can use immediately. I mentioned hydroxychloroquine or Plaquenil, and that decreases viral replication by increasing the pH around the virus. It does modulate the immune system, but there's a national shortage of it, and I think the data on Plaquenil is really pretty skimpy. And then remdesivir, this is the drug I talked about. It's an intravenous medication. We give it for about 10 days, and it does seem to show improvement. Most of the convincing data are in monkey models and green macaques, where monkeys that received the drug did much better than monkeys that did not receive the drug, but there have not been any good studies done yet in humans, although 2 trials are now underway. And again, I mentioned the vaccine situation. It's going to take many, many months, but I do think this will be probably how we get this viral thing under control. And hopefully, unlike influenza, people will go out and get this vaccine once we have it available. The bottom line is it's simple things that will protect us. Washing your hands, of course, is the most important thing. Do it frequently. Try not to touch your face. Try not to touch a surface, contact surfaces. Wash your hands after that. Social distancing is the most important tool that we have right now to protect the community. I think we are seeing some benefits of that here in California, where the population is a little more spread out. and our local governments have been more proactive in encouraging, if not mandating, social distancing sooner. That said, we are now beginning to see an increased number of cases. We just hope that our curve doesn't look like the one in New York, because that, of course, is overwhelming the healthcare systems. And once that happens, that really leads to sort of catastrophe. So this may be our new fate in the world here. Wearing masks in public, we're sort of during the middle of the pandemic. I think it's not a bad idea, certainly when you're going into the supermarket. I think it's reasonable to do that now. There's a lot of controversy about how much protection masks really afford people, but probably some sort of mucosal barrier is better than nothing, as we have a lot of virus circulating through the community. This was a physician during the Renaissance and during the plague. This is a time when healthcare workers really have to kind of overcome their own anxieties and fears about dealing with this disease and step up. I will tell you that I am so impressed with my colleagues, and particularly the nurses. The nurses are really at the highest exposure. They're with the patients for 8 to 12 hours a day. And I have to say, I'm so impressed with my colleagues at the hospital who, without any kind of second thought, go in there and take care of those patients and really do the very, very best they can at their own risk. So it's impressive to see people kind of try to overcome their own fears and produce really good healthcare. These are some helpful sites. Johns Hopkins has a very good site on coronavirus. Of course, the LA County Public Health Department does. CDC is good. CDC has been a little confusing, and I think sometimes that's a problem in terms of different types of preventions, but overall they're a very reliable site. WHO, of course, is good for statistics, and this is our own site that can get you to other sites that you might find useful for your own information. And I'm happy to take questions.
All right. Thank you so much, Dr. Shriner. We really appreciate your time. We appreciate your efforts that you're making, along with all the other nurses and doctors who are responding. We're very grateful for that. I will start off Q&A. Our first question is, how do these epidemics relate to climate change?
Well, that's a good question. I think that one of the things that we're concerned about is, as the planet warms, that it changes the ecology, the local ecology, and really the global ecology, so that animals will begin to move out of areas. For example, mosquitoes are a good example of that. They may move from areas where they never were endemic to areas that they are because the temperature is warmer. And we saw that certainly with Zika virus, another pandemic that we had a few years ago. With regard to this particular virus, again, global warming, habitats are destroyed, animals are forced to move into different areas. If you add on to that the bushmeat and wet market cultures, that really increases our ability to encounter animals that carry pathogens that we've never seen before. So as we intrude into natural environments and the climate changes and those areas are altered, it's much more likely that we're going to encounter pathogens that our immune systems have never seen before, and then lead to further pandemics.
Okay, great. Our next question is, if a person is infected with COVID-19 on day 1, how many days does it take for a COVID-19 test to come back as positive?
So the coronavirus test is a PCR. That means it's actually measuring viral load, and that's probably positive within 2 to 3 days. That may vary a little bit, and occasionally we do see patients who have all the clinical symptoms of the actual disease, which is COVID-19, and yet they have a negative test. When you retest them, they may be positive. So it's not a perfect test. It's got about 98% sensitivity. It's quite, well, not anywhere between 92 and 98%. It may be dependent a little bit on how the specimen is collected, if there was some sort of misadventure during the transport of the specimen. But most people will probably have a positive test within 3 to 5 days of becoming symptomatic.
Okay.
Of course, there are a bunch of asymptomatic people too. I would, that don't really have any disease, don't have any manifestations of the disease, but are viremic and certainly are potentially infectious.
Very good to know. The next question is, how far are we from antibody testing to see if you've had it, or will that help or be possible?
That's a very common question now, and we're kind of excited about it. We're pretty close to being able to have that test. There's a couple of companies some new companies. I know I'm speaking to a bunch of entrepreneurs, and this is a great opportunity for innovative biotech that are developing spot tests that can be done within a few hours, some of them even within 45 minutes. The accuracy of those tests to evaluate for the presence of IgM or IgG antibodies still has to be verified. But serologies are a common type of testing that we already do. And I think that probably the first ones will be access to large testing companies like Quest Diagnostics or LabCorp. It's pretty easy for them to shift their platforms to measure the antibodies to this virus. Antibodies probably appear in the later course of the virus. IgM, of course, is the first to appear, so that might be the better target in terms of assessing immunity. But IgG is more robust for the long haul. How long those antibodies last, we don't know. So it's possible that someone has the disease, develops antibodies, but if we test them 2 or 3 months down the road, they may not have the antibodies. I don't think that's going to be the case. I think the antibody test should remain positive. That may be important for 2 reasons. One is those may be people that we could use as plasma donors for sick people to donate their antibodies to people that are having overwhelming infection. Alternatively, and perhaps more importantly, that may be a way of measuring immunity and the immune response and may be helpful as we develop vaccines.
Okay. Do you see any evidence that COVID-19 is claiming some of the same lives that the normal annual flu would?
Absolutely. And in fact, I didn't mention this, but many patients are co-infected. I shouldn't say many patients, some patients are co-infected. I haven't seen an influenza in coronavirus co-infection, but we do see some other types of viruses, human metapneumovirus, rhinoviruses, and even some bacterial pathogens, something called mycoplasma, and Legionella. Even Legionnaire's disease has been reported in COVID patients. So you do want to make sure that you treat these patients with regular antibiotics for bacterial infections. Co-infection's been reported. It's not super rare, and it's something to think about. The virus behaves very, very much like influenza, and so often we will do a nasal swab for the other respiratory viruses to see if they actually have influenza and not COVID, and that has panned out in many patients.
Okay. The next one is about some studies in different medical journals showing that humic acid can bind to virus sites and help inhibit the reproduction of the virus. There are positive studies on it with many different viruses such as SARS, West Nile, influenza, and HIV. Have you heard about this? Do you know much about this?
I'm sorry, I didn't get the first part of the...
Sorry, it was humic acid can bind to virus sites.
Yeah, you know, these viruses are very sensitive, and the pH of the viral environment can certainly impact these viruses and cause them to denature and die. As I said, these are envelope viruses, and so they're very delicate. The protein envelope that surrounds the virus is very susceptible to changes in pH, to acidity, to other types of proteins that might interfere with viral replication. So that's helpful in terms of controlling spread on contact surfaces and so forth. How that can be implemented in a setting of therapy for a patient might be still kind of unclear. That is one of the mechanisms perhaps of hydroxychloroquine because it alters the pH, but the efficacy of that in vivo is turning out to be not as hopeful as we thought.
Can we go back to your last slide? Some of the attendees are requesting that to see that. Perfect. Thank you. Okay. The next question is, can you comment on local readiness?
Yes, I can, because we've been working very, very hard at this. You know, it's easy to criticize because I think that the federal government was late to the gate on this one. And I'm not going to make any political comments at this point, but I hope that this is a lesson for all governments going forward, that pandemics are something we're going to have to deal with going forward for in perpetuity probably. We need to invest in preparation. We need to invest in infrastructure for healthcare systems and to have an enormous amount of backup equipment when one of these occurs. And I can certainly understand why hospitals and institutions, they don't want to have to carry the expense of having extra ventilators and keeping them maintained and so forth, but this is when you need them. And I do think with our changes on our planet, with the number of people that are on the planet, with global warming, and with a lot of the political unrest, and perhaps more importantly, something that's not a malignant thing, but just the mobility of people throughout the world. Just remember, you can get on an airplane coming from a very remote area and be in a very densely populated urban area in less time of the incubation period of any viruses. So that really probably has impacted this particular pandemic in an enormous way. So I think that preparedness has been a problem. I will tell you that at our hospital, we have had practice runs at this. Most hospitals are required, especially trauma 1 centers, which Huntington is, are required to do exercises, and we have done a pandemic exercise. I alluded to the issue of the Ebola crisis in 2014. It was kind of a strange occurrence. That night I got called to the emergency room, was the week of the Texas case. And I was called into the ER in the middle of the night for a young man who'd returned from West Africa who had a fever. And I asked the ER doc who'd already been in the room with the patient, I said, did you ask him what country he was from, or where he was an American, but where he'd been? And he didn't ask. And he said, why should I ask that? And I said, because we're having an Ebola outbreak in West Africa in 3 countries. This young man was in Ghana, and thankfully he had malaria. Not thankfully for him, but he had malaria. He didn't have Ebola. But it was that night that I realized that our hospital wasn't ready for an Ebola patient. And so for the next month, we spent a great deal of time getting ready for it. And it turned out to be helpful because we had an Ebola room that we had kept in storage. And that room was filled with about 77 PAPRs, which we are now using for this pandemic. So I think that's an example of trying to be prepared for whatever comes your way. And I think Huntington has stepped up. We have a very talented coronavirus task force. We meet every single day. It's everything from stress anxiety in the clinical setting with our healthcare workers to managing surgical schedules and how to deal with the public. And we, of course, are not having visitors right now in the hospital. We are closely linked with our own public health department. Pasadena is fortunate to have its own public health department and with an excellent leader, Dr. Ying Go. And I would like just to do a shout out to Dr. Lori Morgan, who's the CEO of Huntington. She's done just a phenomenal job. She's only been in the spot for 3 years, and she got dealt an enormous task very quickly, but she's just an incredible leader. She's a trauma surgeon by training and is a great listener, but also makes very hard decisions. So I think we are getting there. We are very worried about being overwhelmed. But we have a lot of contingency plans, and we have a terrific group of people at the hospital to take this on.
Wonderful. Yeah, thank you for all of you serving. We're really grateful. The next question is, why is the virus viability so different between porous materials and hard surfaces?
Well, it's the mucous membrane, a mucus thing. It's on a hard surface. You just sort of imagine a little piece of mucus that flies out, sort of distasteful, but flies out. It happens all the time when people talk, and lands on a hard surface. It's suspended on the hard surface. On permeable surfaces, it may get absorbed. Now, there has been some concern about cardboard surfaces, but I actually looked at an old study looking at coronaviruses way before this epidemic, and because there was a lot of concern about money. People were encouraged to use their credit cards and not use real money. But it looks like the porous surfaces may actually absorb it, and then it dries faster. And we don't know whether dried virus is still a potential source for infection. A lot of this stuff is probably being looked at right now. It might be looked at retrospectively, but hard surfaces are more likely to keep a suspended mucus particle and allow transfer of infection. Some of this gets to be kind of into the weeds a little bit. Those of us who have pets, if you cough on the pet and you get a little bit of mucus on the pet, and then somebody else pets the pet and touches their eye, then maybe that's a potential source. There's all kinds of could be infectious potential ways, but I think that at this point we have to kind of look at the most common way, which is close contact with a human being who's infected.
Okay. Will warmer temperatures slow the spread of COVID-19?
According to some people, the science behind that is a little murky. The reason why these viruses are seasonal probably has more to do with UV radiation than with temperature. is some data about temperature in viruses. Certainly, obviously, when it's very hot, it's possible that virus out on mucous or on hard surfaces are going to dry quickly and denature. But it has more to do with UV radiation. And so in the summer months when the sun's up longer, that's more likely to diminish the environment that harbors the virus a little bit. It doesn't do so much for people that actually have the virus in them. The other thing, of course, that happens in warmer months is that people are outside. They're not closed into a house. But I will remind everybody that the virus is currently raging in Australia and in the Southern Hemisphere. And of course, they're coming right now into their fall, but this was happening during their summer. So we can't count on that to be a factor. It is typical for these viruses to be seasonal. What we're very much worried about is that we may get over the hump now and maybe have sort of some quiet months in July and August and then be faced with another round of this in the fall. So I think we have to be very prepared and continue meticulous social distancing and hand washing and so forth for a very long time.
Okay. Is it possible to know that many have already had it and didn't know? For example, they thought it was just a mild cold. Can we randomly test the population to determine this?
That's a very important idea. And actually, I just was emailing someone at Occidental College who's interested in that thought, because it would be sort of an interesting, it would certainly be helpful to test healthcare workers who maybe had it either clinically or didn't know it. And if they have positive antibodies, they may well be protected in the setting of taking care of other patients. But we don't quite know the answer to that yet. And again, I think we need to be very cautious. We don't want to throw people out there who have positive antibodies and say, okay, you can go in there without a mask on, and then they get an even worse version of the disease the second time around. That certainly could happen. Remember that these viruses, they're very inefficient replicators. And so when they replicate, they make a lot of mistakes. It's not common that these viruses become more virulent. In fact, they tend to become less virulent, but it is possible. And that the genetic changes may occur so that you may be immune to one variety of sort of coronavirus, and then as the epidemic continues on, we have a newer variety. I don't think that's going to be the case. We do think that the antibodies will be pretty much helpful for this particular species of coronavirus throughout, but we're not sure.
Okay, that kind of leads to the next question. Any comments on getting reinfected after successfully getting well the first time?
That's a concern. We hope that doesn't happen. But sometimes people also have an inefficient response. People that are taking immunosuppressive drugs or who have other comorbidities, they may not mount a good response to this virus and potentially could become infected again.
Okay. If you donate plasma, does your body continue to make more antibodies so you can donate multiple times?
Yes. The little cells called B cells, they're the part of what we call the humoral immune system. They make the antibodies, and they're very good at that. So you can donate away, and then within hours you'll have a whole new supply of antibodies. So that is a good thing if we use that technique to treat very sick patients.
Okay. If it were up to you, how long would you continue the lockdown?
Well, I'm not really locked down because I go from my home to COVID Central there, which is also called Huntington Hospital. So, but I do think we need to be very, very cautious with this. It's going to be hard for people because, we live in a democracy, and so in that situation, we're used to a lot of freedom and not necessarily being told what to do. But this is the most important time to really do good epidemiology and for people to stay away from each other, even in families. And it's very hard. I'm lucky because I live alone and I don't have to deal with that. But many people have family members, and so they have to really try to do social distancing. It's difficult to do that with children, obviously, not to mention the fact that the kids are cooped up. And I'm sure there's going to be a lot of frayed nerves here in the next few weeks. But for the next 6 to 8 weeks, it's super, super important that we continue to do really, really good social distancing, hand washing, and really rethink perhaps how we conduct ourselves. Maybe the days of cramming everybody into large venues and having very small spaces is not a good idea. Or perhaps the cruise industry, I think, needs to revisit how they function. So I think there's going to be a lot of changes in how we conduct life. Hopefully we'll learn good lessons that will protect us from future problems.
Yes. If you've been quarantining for the last month and show no symptoms for COVID-19, can you presume that you're negative?
Probably. We think about 14 days is a good quarantine number. And so it's unlikely that you're infected. You know, nobody can go into quarantine for, you know, years and years and years, because at some point you have to get some food. We think that you know, 14 to 21 days certainly is probably good in terms of no symptoms, that you probably aren't infected.
In the future, do you think that there is artificial intelligence or like robots that can be used in such a way that protects nurses in these types of pandemics?
The future is here. It's called Bluetooth. And so we do have a lot of telemedicine type things. We have devices now. Our emergency room has Bluetooth stethoscopes, and what it is a stethoscope that the device, the little bell of the stethoscope is given to the patient, and they place it on their chest, and it allows the physician outside the room to listen to their lungs and heart. It obviously depends on a patient that can do that. If they can't do it, then the nurse can move it around for them. We are trying to keep the number of people who encounter patients to a minimum, because we just have such a problem with personal protective equipment that we don't want to have 25 people going in and examining patients. We just really are trying to have it as sort of one person who does the exam, and then the rest of us use the clinical information from that exam to make our decisions.
I've heard that the virus can live for 2 months in the freezer. Can it be killed by boiling water?
I'm sure it can be killed by boiling water. Probably the real cold may also help it. You know, that is a potential source of infection, I suppose. But, you know, if you think of all the possible permutations, you'll sort of lose your mind, I think. So you have to kind of just think about the most likely ways of contracting the virus. But boiling water certainly will kill, and thoroughly cooking things will certainly kill the virus.
Okay. And how can we immune ourselves better against the virus in case we do get this, even after following all the possible precautions like social distancing?
Well, your immune system is very sensitive to rest. So getting plenty of sleep is obviously a very good idea. Having good nutrition, getting some exercise, stress relief. Stressors are very, very hard, and, you know, everybody's under stress right now. And, you know, it's a scary thing. I was thinking the only place, I don't think Antarctica has any COVID, but the only other place is the space station. And so the folks that are up there looking down on us and thinking that whole planet's just infected, which is sort of a scary thought. There's really nowhere to go with this. So we're all going to be under the stress of having to deal with this infection. And I think it's the unknown that's so scary. Stress itself does affect your immune system. And so it's good to have means of relieving that stress, whether it's getting some exercise, whether it's playing some music or listening to music or doing some art, things that are going to get your mind off of it, cooking. You know, our usual social activities are somewhat limited with this, although people are becoming very creative with ways of communicating.
Hence our Zoom meeting today. I think, sorry, go ahead.
No, this is a good time to invest in Zoom.
Right. We're going to wrap up our questions here in a second, but let's see what we can get in. Given the low amount of testing so far, how many people are likely to be infected but not confirmed or don't show symptoms? I.e., what do you think the real number is that is infected?
I have really no idea. I hope it's a very high number, truthfully. I think that as the testing becomes more available, that is something we really need to do. Pasadena is looking into having a large testing site at the Rose Bowl that will give us some idea of what our community looks like in perhaps LA County. If you look at the data from South Korea, anywhere between 5 to 10% of the population had apparently reported no symptoms and were positive or had evidence of having had infection. So I think that's where the antibody testing will be most helpful looking back. It is entirely possible the virus circulates among people and causes mild disease, but provides protection. And that leads to what we're trying to achieve here, which is called herd immunity, where the herd becomes more immune to this virus. I always kind of like to think of it as kind of like fleas on a dog. If the dogs are kept apart from each other, the fleas can't jump off and jump from one dog to the next. Also, if the dogs become immune to the fleas, then whether the flea jumps on you or not, it doesn't make any difference. So that's kind of a good way of looking at it.
Great. Well, we are at just about 9:30. Thank you, Dr. Shriner, for answering all those questions. We feel so privileged to have you here with us. Any last thoughts or anything else you'd like to share before I say a few words and close us out?
Well, today is Jane Goodall's birthday, and Jane is actually a very good friend of mine, I'm very delighted to say. And I think I talked to her last week, and her hope is that out of this terrible pandemic that we have, a lot of good comes. Respect for our planet, respect for our species, reaching out to help our fellow community members, doing things not just selfishly, but for the whole community, and perhaps protecting this little green orb that we fly around on so that future generations can enjoy nature and have a healthy life.
That's amazing. Thank you for sharing that. And for all of the people who attended today, we really appreciate you coming out. We hope to see you next week. Next week, we're going to be talking about preparing your company for growth round with Aaron Zeitzman of 3L Capital. And in the meantime, we hope that you all stay safe and well. Have a wonderful weekend, everyone, and take good care.
Thank you.
Thank you.